Good morning, everyone. Welcome back to UofT Grand Rounds. We've had hiatus for a couple of weeks. And today, what we'll be doing is a annual review of the Walter Wright course. So this year's Walter Wright, for those of you who are there, was on cornea, anterior segment, and refractive surgery. We're gonna get an echo. And it was hosted by our esteemed cornea faculty, Dr. Hall Chu, Dr. Neerav Singhal, who are both here with us today, as well as Dr. Josh Teichman. And I want to take this opportunity to really congratulate all three of them, as well as the entire planning committee led by Dr. Alan Slomovic, on a very successful course. This was our first Walter Wright, or actually, no, this is not our first Walter Wright, but it was a very well-attended Walter Wright, probably record attendance, extremely well received. I've received lots of good feedback personally from many attendees. So I do want to personally congratulate all three of the core directors, the entire faculty, and Dr. Slomovic and the planning committee on a very successful Walter Wright course. And with that, I will hand it over to Dr. Chu and Dr. Singhal to give us a review of what we learned this past weekend.
Okay, thank you, Amandeep, for the introduction. Appreciate that. And I'd like to give special kudos to Dr. Alan Slomovic. He's the true master of disaster when it comes to organizing Walter Wright. I know that he lived and breathed Walter Wright Symposium as he started the planning for the 2023 planning just yesterday night for next year. So it's a 365 with Alan for sure. Thank you, Alan, for everything. I think Alan made a huge impact on our department, obviously, but you know, his dedication to Walter Wright Symposium is amazing. He helped drive us through, and you're able to have, I think, one of the best Walter Wright Symposiums ever. You know, when we first, when Sandra said we had to do this Walter Wright review, we were looking at it like, oh my God, there's a lot of work to do. I looked at what Kirill and Marco did last year. It was amazing. So, you know, this won't be up to snuff as good as those guys, because those guys are super residents. I'm just a, you know, cornea guy here. But the thing is, you know, the one good thing about this though is, and I have to say, you know, reviewing all the talks from last week, it really does cement a lot of and it's more impactful, the information that was given and disseminated, and really is great. And I think it's great for the residents, you know, for studying. You know, when you see something in clinic and you go back home and you read about it, or when you know, have a teaching session and you review it again, it really cements everything in your head. So it's really good. So I think this is a very timely thing to do. So I'm not going to waste everybody's time here. We got 45 minutes or so to do this talk. And we're just going to hit all the key high points on this, and you know, we stop periodically just to see if there's any questions and go from there. So again, as Hamdeep said, it was the most successful by attendance. It was amazing, great turnout for cornea. And we'll start first. Our first session was on, see here, was Dr. Elmer 2. We started with infectious diseases. And again, these are just short tidbits, just hitting the high points of everything here. So corneal ulcers, when to treat, when to refer, and what not to miss. So bacterial keratitis, the majority of microbial keratitis in developed nations is bacterial in origin. Single drug therapy, specifically talking about the fluoroquinolones, is effective in curing bacterial keratitis in most cases. Emergent treatment is critical. When to treat, Elmer was saying almost always. Atypical keratitis is what you do not want to miss. Anything other than routine bacterial keratitis, such as fungal or acanthamoeba, you have to, those are things you want to look out for. And things to ascertain are, is there an atypical history? Are there risk factors, or how the prior clinical course was doing? Obviously, if the case wasn't going well, there's something different changing. Sometimes you have atypical presenting features, you know, to satellite lesions, maybe you know, pain out of proportion to what you would normally see, or an atypical response to routine antibacterial medications. That's not working. So when do you refer these? When you have a suspicion of atypical keratitis. If there's the use of corticosteroids, you know, it seems to be worsening, and always be cautious when you're using corticosteroids too. Also, if prior antibiotic is being used and it's worsening, those are issues where you may want to re-refer these patients. And this brings a very good question. Like, there's one thing that Dr. Chu talked about was the SCUT trial, which is the use of topical steroids in culture positive ulcers after 48 hours of initiating antimicrobials, which may improve long-term clinical outcomes in bacterial corneal ulcers not caused by nocardia. So this is a nice study that showed that there was some benefit in resolving the scar much earlier. But I'd like to know what, there's a couple of points here. This is not so that everyone is supposed to start using steroids at 48 hours, because this is for ulcers that are culture positive, which is not, not everyone has the ability to perform cultures on these patients. So do you start steroids on everybody after 48 hours? The other is, how do you know if it's not nocardia or if there's something else or some other atypical issue? So I thought this was a very good trial for people. If you have culture positive, it ticks all those boxes. But for the community ophthalmologist, is this the right thing to be telling them? So, Alan's on the panel and John Lloyd's on the panel. Just wondering what your thoughts were of that. If you have any feedback on that about starting steroids in 48 hours, let's say if you didn't have cultures.
Paul, it's funny. I learned this when I was a fellow in Bascom Palmer, and Sid Mandelbaum particularly always used to say, don't start steroids until you have a bug, a drug, and subjective improvement. So those are the three strikes that I still use to this very day. I think that rules out, if you have a bug, it rules out, you could have mixed infection too. I've had acanthamoeba and E. coli, which we published way back when acanthamoeba, we started diagnosing it, but pretty much the subjective improvement, the sensitivities. So that's what I use, and it's held me in good stead ever since.
I think those are excellent points. And the other issue too is, in the study, I think at 1 year, I think the outcomes were very similar in terms of the vision. So, I think to err on the side of safety, especially if you're in the community and you're not sure what's going on, until you really are sure that things are improving, you won't be faulted for holding off on the steroids, I don't think, because what if something bad were to happen? What if you were to all of a sudden give the diagnosis of HSV or fungus because you start the steroids? So it's just something to think about. I don't know what your thoughts on that.
Oh, one more quick point is that, when I speak with the fellows about treating referred infectious keratitis, the first marker you're going to see is the next day, they feel a lot better if you've got the right treatment. They can look worse because you're killing the bacteria, you're releasing all kinds of lytic enzymes. So often they'll look worse on day one, but they'll feel better. And when they feel better, and that's the first thing I ask them, when they feel better, you're on the right track.
Yeah, excellent. So also Dr. Tu, who's like a world-renowned medical corneal specialist and surgical corneal specialist, but he's really well known for his acanthamoeba and kind of atypical ulcers. Kind of ran a discussion. We had 3 cases he presented on acanthamoeba, one on palithoa, which is a coral, and palycoxin keratitis. And he also mentioned that some other cases may take longer therapy to get through these typical cases. Our next speaker was Dr. James Chodosh, who is the mentor of Dr. Stéphane Longton at Mass Eye and Ear, very renowned corneal person. And he gave an update on HSV anatomical classification and treatment algorithm. So the various manifestations of HSV can be confusing. Historically, the terminology can be confusing and it can lead to errors in treatment. So he proposed, and which is being more accepted, as an anatomical approach to classification, more precise and easier for treatment. He also said that steroids in patients may be required long-term. And this is a very important point here. One of the key take-home points: beware of discontinuing steroids in someone who has chronic disease, although they may look quiescent, especially tapering after cataract surgery or other ophthalmic surgery. So just this week, I had somebody who came back to me who had a DSEC done for a traumatic corneal condition, and he was required glaucoma surgery and did very well. The pressure's lower now, but unfortunately, they stopped all the steroids and the patient rejected immediately. So I think it's something that everyone should be aware of, not only just non-corneal people, but even corneal people. Maybe there's when we're looking at treating people who have glaucoma and we say, oh, maybe we should stop this drop or that drop, we should really make sure that we contact the other doctors just to make sure there's a reason for why they need to be on a certain medication. So this happens quite commonly, especially in HSV. You do cataract on somebody who has HSV, and maybe you stop their acyclovir or stop their steroids where they really need a very slow taper of it. So just be aware of that. It's a very important point. And again, long-term antivirus prophylaxis is required for chronic patients and post-transplant. And again, another point, monitor the renal function annually, have them checked by their family doctor. So the anatomic classification, I made this little chart here. As you know, the alternate terms on the right are kind of the ones that we've learned from decades ago, the dendritic, the geographic epithelial ulcers, which are also now known in what Dr. Chodosh is mentioning as HSV epithelial keratitis. And then in the stromal side of things, there's non-necrotizing keratitis, interstitial keratitis, immune stromal and necrotizing keratitis. You have the two, basically SK without, or stromal keratitis without ulceration and stromal keratitis with ulceration. And then an endothelial, our classic disciform keratitis, which was drilled into me by the famous Dr. Cal Breslin with many expletives, it's actually the HSV endothelial keratitis, another way of classifying it. Dr. Chodosh then gave a talk on HZO, zoster keratitis, which is a little bit more complex than HSV. Basically, the vaccination prevents HZO from occurring. And the criteria in the UF and here is any patient over the age of 50 years old qualifies for the vaccination, and any immunocompromised individual over the age of 18 should also get the Shingrix vaccine. So there are unresolved issues in the management of corneal disease in HZO. It's unclear whether antiviral prophylaxis, if it prevents or reduces recurrences of HZO, meaning keeping somebody on long-term Valtrex or acyclovir or Bambir. The ZEDS study, the zoster eye disease study, is a randomized clinical controlled trial which is ongoing. But unfortunately, the study ends in 2 weeks' time in terms of the recruitment. And one issue is we're not sure if we have enough numbers there, so this may not resolve the question as of now. And there are some good data that show that corneal neurotization and topical recombinant human nerve growth factor have been well studied, but they've not been well studied in neurotrophic keratopathy secondary to zoster, but they do hold significant promise. Okay. Our next speaker was Dr. Watson from Australia. She came the farthest. She's actually a world-renowned stem cell transplant specialist and corneal specialist from Australia. So she talked about managing ocular allergies, AKC and VKC. So basically avoid the allergens and use simple measures. The typical first-line topical therapy is necessary. Second line when improved topical steroids and immunomodulators. And VKC and AKC, because of this steroid use, have higher risk for developing glaucoma. It could be due to the inflammation, the chronic inflammation, or it could be due to long-term steroid use. And sometimes systemic therapy is required, such as the big guns like cyclosporin, tacrolimus, and other biologics, which may be effective in some patients. And even performing surgery for non-healing shield ulcers is something that could be helpful. So her next talk was on the registry that she does. There's a snapshot of local and national outcomes from microbial keratitis and keratoconus, including collagen cross-linking and stem cell therapy. To summarize this work, which is a huge amount of work, which is amazing data that they're able to go. I mean, we're talking to some of the people there were saying this is incredible data from some of the other speakers that are there. Real world data across multiple countries is an international registry that she has, which Dr. Singhal is coordinating for us to incorporate for it. So that collagen cross-link is an effective treatment for progressive keratoconus. Positive outcomes including improved visual acuity, stable Kmax, et cetera, sustained at 5 years. Most patients with dry eyes have tear evaporation as the cause for dry eyes. Under microbial keratitis, it's very important to know the local antimicrobial resistance in the area, which helps to inform your treatments. And that just does change from country to country and from continent to continent. For HSK, the registry helps to tailor treatment guidelines as well. And she had a nice case about this poor young kid who had a Coke and chips diet with severe vitamin A deficiency, and always get a good dietary history when things don't make sense, especially in people who have poor absorption of vitamins due to maybe diet or other causes. Dr. Singhal gave one of the best lectures out there. collagen cross-linking for patients with keratoconus, lessons learned from the Jimi Hendrix experience. Identify keratoconus patients early. High-risk patients are patients below the age of 18 or Kmax greater than 58. That's a really key point there. Those patients, if you're diagnosed much earlier and having shown progression at an earlier age, or if your Kmax is really high, you're probably more advanced and have higher risk for getting progression. So those are key points to note, and maybe higher triggers to make sure that they get taken care of sooner, prevent them from getting worse. It's recommended for the treatment of keratoconus and does stabilize disease, can treat with historical progression. So if there's a history of people progressing and they meet the criteria based on their age and risk factors, should go ahead and refer in or perform the cross-linking. The procedure is well tolerated and low risk, and you have to rule out other therapeutic options. As Dr. Clara Chan is very, very good to note when she teaches the residents. Make sure you rule out sleep apnea in these patients. There's a high indication for that. Something you can save their lives on later. Help them get them CPAP or whatever, prevent them having strokes, etc. Treat underlying inflammation, stop eye rubbing, and sterile contact lenses are sometimes very helpful. Topo-guided PRK can improve symptoms of halos and glare, and femto intact segments can also improve vision. Dr. Teichman gave a great talk on corneal topography, tomography with comprehensive ophthalmologist. Basically, he distills it down as have an approach, be aware of artifacts, and assess quality. Be aware of the maps, scales, control the technology, not the other way around, and don't rely on the overview. Look at the details. You have to look at each detail, look at the granular details, make sure that you're getting the right data. Customize your displays so it's very easy for you to read it, and the pattern recognition is a little bit better for you. You can understand things better. Different display for, use a different display for keratoconus diagnosis versus your IOL selection when you're using it primarily for patients for cataract surgery. And of course, as he says, for all radiologist reports, I always say clinical correlations required. When you have your readings, you must also compare that with your exam, your physical exam. Is there something else going on slit lamp? Is there ABMD or Saltzman's or something else? And of course, read the manuals of your topographer, tomographer to help you understand the nuances better. And we also reviewed some cases that we went through there. So Dr. Sadir Hanish, world famous anterior segment surgeon, DALK for the management of keratoconus. Basically, DALK is deep anterior lamellar keratoplasty. It's usually used for keratoconus, corneal scarring, and conditions where there's a healthy endothelium. Dr. Hanish recommends that DALK be performed if the endothelium is healthy in any type of condition, where you're just removing stromal scar or epithelial scarring. The advantages of DALK, it's a more secure wound because you're retaining the patient's own epithelium descemex membrane. There's a lower risk of rejection because there's no endothelial rejection. There's reduced amounts of steroids required because of this, which then leads to less chance for glaucoma and infection. And finally, and also improves healing, because the more steroids you use, the harder it is for things to heal. And finally, one of the more important things is no open sky, meaning we don't take everything off and all of a sudden you've got atmospheric pressure and you could expulse and get a suprachoroidal hemorrhage, which of course is devastating to the patient. And so those are all very good take-home points. So why doesn't everybody do DALK? Well, DALK is actually very difficult. In my hands, as Sadir would like to say, my hands, but in my hands, I'm not that good with the DALK, to be honest with you. I get a big bubble once every 10 tries that I get. And it becomes a very laborious type of surgery, but it is worth it if you can do it for the patient. Okay, Dr. Stephanie Ramdas, who runs the Kensington Eye Institute contact lens clinic, gave a talk on contact lenses for ectasia and an update on the PROS lens. PROS stands for Prosthetic Replacement of the Ocular Surface Ecosystem. It's a great name, but some other people thought PROS stand for Perry Rosenthal. It was a shortage for his name, but who was the person who actually developed the PROS lens. But anyways, the criteria for PROS candidacy here in our city here is basically you have to be an Ontario resident, 20/40 or worse in the better eye with history of failure with contact lens. Keratoconus was the most common indication for PROS. Kudos again to Alan Slomovic for developing this program and making it available to patients who really need this, before people would be sent to Boston all the time to get this done. The challenges with this lens decentration, residual aberrations, and lens characteristics were discussed by Dr. Ramdas, and follow-up is very important to look for inadequate fit and compromised corneal health. Dr. Ray Stein gave a very excellent presentation on emerging refractive techniques and technology in keratoconus management. Basically, collagen cross-linking is done to stabilize the disease. It does not correct the astigmatism. It does show some flattening, but not in most cases, not enough to make a huge improvement in some cases. So the goal is to improve visual acuity and quality of vision. So Dr. Stein talked about collagen cross-linking combined with total guided PRK. He said the best candidates are those whose spectacle visual acuity is 20/30 or worse, minimal minimal corneal thickness greater than 430 microns, and total changes in the pupil zone. They must have clear corneas and less than 10 diopters of astigmatism, because he feels that you can correct, 5 diopters on either side of the astigmatism to flatten the steep side and steepen the flat side to give better, less astigmatism that way. He also commented on Intacs and a newer technique, which is similar to Intacs, but it's called corneal allogenic intrastromal ring segments, where actual corneal donor tissue is placed in instead of the Intacs. As well, he talks about intracolumnar lenses and the IC8 pinhole implant. And in the future, he talked about bioengineered porcine corneal tissue inlaid with collagen cross-linking. One of the highlights, I thought one of the most impressive lectures of the whole weekend was Dr. Aldave's talk on ethics and professionalism, which was the Jeff Hurwitz named lecture. There's a growing interest in global health and international ophthalmic care. And, it sounds very straightforward. We go over there and we help people and we do this and that. And we come out and we do so much good for people, but there's a lot of ethical and professionalism implications there. There's in terms of managing these things. In terms of the training, you have to say, what are the goals, roles and goals? Is it for domestic trainees to go over there and learn on people that are just begging to get their cataracts done? And it shouldn't be. It's there because you're there to help train the local people, make people better. Also to train the domestic practicing ophthalmologists that are there. It's also there's some issues with problems there. You have to make sure that ethically you're not going there just to train your own people. You're there to train the people there to help them to get off the ground and get better. Competence, you have to be competent in the procedure that you're going there to teach, and not going out there to practice to improve your skills on something because you don't have the follow-up, right? The clinical care, informed consent, there's some issues with that, the communications, interpretations, translation, pre-treatment assessments, live demonstration surgery. Some people are doing it because it builds their CV and makes them look like, make them more prominent in the argument. Really, live demonstrations, are there to educate, and that's the main purpose of that. Post-operative care is a big issue. You go there for a one couple day mission or 1 week mission. Who takes care of these patients afterwards? So you have to make sure that all these things are in place. Patient privacy. Some people are putting their things on Facebook or on Instagram or SnapTwit. You have to make sure that you don't, you're not basically, showing these patients from different countries, using them as part of your website to improve your and up as a commercial for your website. So the AAO's at Redmond Ethics Center is an excellent resource which goes through all this. It was a great presentation by Dr. Aldave. Dr. Christian,
if I could just interrupt for 1 second.
Yes,
I think
go ahead.
I want to just say that was an excellent summary of that lecture, but that was just an excellent lecture in general. I think many of us do international work, and we need to be totally aware of some of the blind spots that we can have when we do this work. And Dr. Aldave did a great job at highlighting that. And I think it was a perfect first Dr. Jeff Hurwitz named lecture, because Dr. Hurwitz had a great impact on international ophthalmology, especially in the Caribbean, which continues to this day. And to have Dr. Aldave speak specifically about doing international ophthalmology right was just a really appropriate choice for that lecture. So thank you for having him.
Yeah, no, that was a super highlight. It was a well spoken, but it was just brought a lot of things like things that I never thought about that made me quite aware of things. It was very, very, very thought-provoking. Chris Rapuano, the original editor of the Will's Eye Manual, was here. He gave his talk on pterygium surgery. Pterygium are common. Symptoms can vary. Medical treatments can help, but surgery is usually successful, but not perfect. Conj autograft is the gold standard. Amniotic membrane has much higher recurrence rates than conj autograft, so it should be used judiciously, and fibrin glue works. And patients need to understand there's a risk of recurrences, which can be worse than the original. Carol Cart, probably one of the top ocular surface tumor people in the world. He gave great talks, talk about complexion-associated melanosis and nevi, which are both benign. But for nevi, there's a low rate of progressing to conjunctival malignant melanoma, less than 1%, so it requires serial observation. And that can be done by any ophthalmologist. PAM is a little more worrisome. If there's no atypia, there's zero risk for progression to a conjunctival melanoma. But if there's severe atypia, up to 49% of these lesions can progress to become or to convert to become conjunctival melanoma. So the management in these, as shown here, is observe small lesions, which are 1 to 2 clock hours, excise the medium ones, which are 2 to 7 clock hours, and you can use map biopsy for large lesions, plus or minus cryotherapy. Topical chemotherapy is used for inexcisable disease, mitomycin C is used, and cryo for recurrence, chemo reduction with mitomycin C, 0.04%. Conjunctival melanoma can arise from typically PAM with severe atypia, 74% of the cases. They can also arise de novo, or they can come from nevi, which are much less likely, but possible. Also, back to complexion-associated melanosis, you have to also remember that although someone who's more darkly pigmented may have all these lesions, you have to be aware that they can also still develop conjunctival melanoma. Just because they have a dark lesion there doesn't mean, oh, it's just complexion-associated melanosis. So you should be aware of that. So conjunctival melanoma is unilateral, immobile, vascularity is elevated. It can also be amelanotic. And surgery is usually with local excision with no-touch technique. Plaque therapy is required, oncology workup, sentinel node biopsy are all issues. And now there's more treatment options, including BRAF inhibitors and checkpoint inhibitors. Chris Rapuano, again, one of the world's experts on PTK, talked about EBMD, saying that superficial keratectomy is successful, important to perform before IOL calculations, so there are difficulties obtaining Ks for your cataract surgery. He also talked about recurrent corneal erosion prevention, including preservative-free artificial tears, treating dry eyes with blepharitis, and using ointment at nighttime. When medical treatment fails, try bandage contact lens for 3 to 6 months, changing the lens every 1 to 3 months. If that fails, consider epithelial debridement performed at the slit lamp, or using PTK, which has a little bit better success, or superficial keratectomy with a Diamondberg debridement, which is usually the best one. An interesting comment, which you have to remember too, we all have these little burrs that we use to remove foreign bodies out of, or rust rings out. They're very small diameter. If you use that, that's the wrong one to use. Don't use that, because that will actually cause severe thinning and change the shape of your cornea. So in conclusion, he said, recurring corneal erosions are common, recognize them early. Numerous treatments are available. Important to proceed with surgical options if medical treatment's not working. So the alphabet soup was explained by Dr. Sudhir Hanish, the corneal transplant alphabet soup. We had a couple of years ago, somebody asked me, what do all those letters mean? So here they are: PKP, penetrating keratoplasty, and K-Pro, keratoplasties. These are full thickness transplants. K-Pro is for basically transplants that have failed multiple times, or any area where a typical transplants will not withstand, such as bad conditions, ocular surface conditions in some cases. DALP we talked about. DSEC or DSEC is Descemet's stripping endothelial keratoplasty, which was the precursor to DMEC, Descemet's membrane endothelial keratoplasty. DSEC is typically used for more complex cases, or but they're both very good conditions for endothelial disease. It depends on the surgeon's preference. And DSO/DWEK, DWEK are the same thing. But it's Descemet's stripping only, or Descemet's without endothelial keratoplasty. And these are pioneered by Kathy Colby and Greg Maloney and Stefan Ongtone's doing some amazing research on this, where you remove the central decimase membrane, the healthy endothelial cells migrate inwards from the periphery. This covering the area is used in cases, a select number of cases where there's only glutata centrally. And the advantage, the patients do not have natural transplant, but it does take them a lot longer to clear. So we talked about Ask the Experts, cataract surgery in patients with ocular surface disease. We had a case on OSSN prevented by our fellows. Erica did a great job on this in OSSN in patients prior to cataract surgery. Basically, take care of the OSSN, the squamous cell carcinoma on the eye first before you do any cataract surgery, and wait enough time afterwards before you do any cataract surgery. Of course, tumors take precedence over the cataract. Fuchs corneal dystrophy and cataract. Main point was make sure you target a little bit more myopia, about -0.75, before if you have any inkling of getting a DMEC afterwards or DSEC afterwards. HSV keratitis and cataract was a very good talk, making sure the eye is quiet before proceeding with cataract surgery. Okay. Dr. Aldave came back, genetic testing, diagnosis of keratoconus, inherited disease. The indications for genetic analysis include the inheritance pattern, when there's an absence of a family history for presumed autosomal dominant dystrophy, when there's an absence of typical associated symptoms, and when there's atypical clinical features. So these are cases where genetic analysis for the cornea may be indicated. Also, he also proposed this for some refractive surgery procedures, primarily LASIK and PRK, where there's some cases where it ignites something, specifically lattice corneal dystrophy, which may be not known or not seen predominantly, and then the LASIK kind of flares up and you get these terrible cases happen. So it's rarely, but it can be helpful. Dr. Karp, diagnosis and management of OSSN. Excision and cryotherapy is successful, but extensive surgery can lead to stem cell deficiency. So you can use topical mitomycin C or 5-FU and interferon, but the interferon, least toxic, most expensive, not available from Merck. 5-FU, a little more toxic, it's cheaper, it's available now, QID for 7 days, cycle it 21 days off, do 4 cycles of it. Mitomycin C is the most toxic, relatively expensive, very similar, QID 7 days and off until quiet, 3 to 4 times a day, but is much more toxic, can lead to limbal stem cell deficiency, and punctal plugs are usually required. She also mentioned her research on high definition resolution OCT, which can be used to image the tumors rather than performing biopsies. She also gave a great case about OSSN that was treated, had cataract surgery done approximately 2 years later, and then afterwards the OSSN went through, probably was there some remnants of it, went through the incision and into the eye, and the patient lost the eye. So always, Bowman's layer is strong, does not allow invasion unless you create an incision. So always be wary if you're doing cataract surgery in somebody who's had previous conjunctival lesion. Dr. Tu then talked about management of non-healing epithelial defects and neurotrophic ulcers, eliminate extrinsic handicaps to reepithelialization, optimize ocular surface for epithelial migration and growth, and identify intrinsic factors inhibiting epithelial healing, such as targeted therapy, and also serum tears, growth factors, and neurotrophic factors. Dr. Watson, the approach to the chronically red and irritated eye, take care of the toxicity, observe the conjunctival reaction. If it's papillae, you know that's usually due to one of these causes of allergy, foreign body, contact lens wear, or bacterial infection, and of course, rule out chlamydia. And the approach is to identify or define it, dry eye being the most common cause of ocular surface disease, and optimize ocular health, and talk to the patient, get them on board, and provide medical and or surgical therapy. Then one of our last keynote speakers for talks for Dr. Watson was a limbal stem cell transplantation, where we are now and where we'll be in 10 years. There's some limitations in stem cell transplantation as listed here. The research in stem cell transplantation is ongoing. There have been alternate cell sources and substitutes such as hair, teeth, skin, mesenchymal cells and mesenchymal cells, exosomes and mRNA, and gene therapy. Hello, OR4, sorry.
Sorry about that. We just got a little technical difficulties there. Both Hall and I and Nira actually are multitasking. We're on the OR at Kensington today. So we'll just give Hall a second there.
Okay, thanks. Sorry about that. Okay.
All good, Hall. Thank you.
Yeah. And so where we'd like to be, so obviously improving the diagnosis, improving the treatments, looking at research of stem cell behavior, and informing the community, give them understand the benefits and limits. And the Lancet has a very good information base on stem cells and regenerative medicine. Basically, need more funding is required for these therapies, make them more cost effective. And we have to make sure that patients are realistic with their expectations. Okay, so I gave a talk on AMT for ocular surface disease. I think it was a really good talk. It was techniques for AMT we talked about, and how to use an inlay and overlay sandwich, in-office dehydrated amniotic membrane. And we looked at how it was used to treat ulcers and perforations. It's used in severe cases of dry eyes, can be used in pterygium, but again, AMT has doubled the recurrence rates of conjunctival autografts. Chemical thermal injuries may be equivocal in its use. And Stevens-Johnson syndrome and TEN, in severe cases where there's epithelial defect, lid margin involvement, or conjunctival involvement, the earlier the diagnosis and treatment, it is better. The procedure can be performed at the bedside as well, with good results. The last talk on Friday, Dr. Chodosh, artificial corneal transplantation. He talked about Dr. Klaus Dolman's development of the Boston K-Pro, which he worked on for 5 decades and has helped over 10,000 patients worldwide. However, it is far from perfect. There's a lot of issues with it in terms of infection, the biointegration, inflammation, glaucoma. Newer designs, such as the Coordinate Pro out of Israel, which Dr. Rootman and Dr. Slomick have been involved in, must be tried and tested to be improved. So Dr. Amandeep Rai, somebody we've all heard of and we know and love, gave the anatomy of biometry. This was the first talk on Saturday. Modern forms are not just the Barrett through K, should also consider using the Kane, Olsen, Hill RBF in certain scenarios. And the posterior cornea you should be made aware of, and it's largely resolved using the Baylor nomogram. And you get good toric results with both predicted and measured posterior corneal astigmatism. Overall, the evidence is not clear that measured is better than predicted. But basically, Amandeep's take-home point was make sure you're aware of the different calculations possible out there, the formulas out there, and that may fit for each case. Anything more you want to add on that, Dr. Rai? No, you summarized that perfectly, Hall. Thank you. Well, I think I did because you gave me the slide, so thank you. Okay, Dr. Ike Ahmed, the man in the bag IOL exchange, in the bag IOL exchange techniques. Reasons after you rule out ocular pathologies, uncorrected refractive error, inadequate range or near halos, glare, dysphotopsias, quality vision issues. So considerations, you have to look at the IOL design and materials, whether there's a significant capsular fibrosis, how long post-op, beware of zonulopathy. I thought it was very interesting. Ike mentioned, even if there's a YAG capsulotomy, you can exchange the lens. But again, that's, again, it has to be, you have to be comfortable with that. For Ike Ahmed, that's not a problem. For the majority of us, I think we'd have to be very careful with that when there's a capsulotomy already. The goals of IOL exchange are use the correct IOL design and power and cylinder calculation, safely remove the current IOL, retain capsular support, do not have any loss of vitreous, and make sure the IOL is implanted in a stable location. Dr. Matt Schlenker, glaucoma specialist extraordinaire, pearls from the glaucoma specialist to the anterior segment surgeon. So I question whether or not David Yan made this title as making fun of the anterior segment surgeon, just as he did with the Wong Trope Feldman Award. Anyways, strive to reduce glaucoma drop load, be vigilant for intra or post-operative malignant glaucoma, prevent iris prolapse, managing the small pupil, and be ready for zonulopathy. So always, these things are all important when you're doing anterior segment surgery or glaucoma cataract surgery on these glaucoma patients. Of course, watch for their IOP spikes, nail the refraction, and evaluate the optic nerve. Make sure there's not another cause for reduced vision, not just glaucoma. Make sure that the retinal nerve fiber layer is okay. Dr. Terry Kim from Duke University, who's the ophthalmologist for the Duke basketball team, very prominent gentleman. Capsular support devices and fixation techniques and zonular instability. Yeah, basically in cataract surgery with zonular loss, use proper phaco techniques, proper capsular retention devices, support devices, and proper IOL selection. They all help to achieve an excellent anatomic and refractive outcome. Dr. Hanisch is back speaking about the capsular IOL implantation without capsular support and the new range of the Yamane technique and the Canabrava techniques, which simplify scleral fixation compared to the previous predecessor, which is a glued IOL technique developed by Dr. Agrawal in the past. The Yamane and Canabrava, they avoid conjunctival takedown and scleral flap recreation, and they can use and the needed fibrin sealant, and generally much more efficient. However, there are complications. The main issues are IOL decentration, rotation, possible pupillary block, as well as haptic extrusion through the conjunctiva. And then Dr. Hanisch talked about the artificial iris, why, when, and how. He used it for all these indications. The most common cause lately, he says, is due to severe iris atrophy after TAS. His conclusions: the why, symptomatic iris defect not amenable to primary repair, painted contact lens, or keratopigmentation. This is an elective procedure. And in order to do this, you require certification by the company, which is usually Mortar, as well as preparation, using wet lab, complex order of device, and then informed consent and surgery. Dr. Kim was back talking about presbyopia correcting lenses and eye drop therapy for presbyopia. So the goal is to create a pinhole effect and extend the depth of focus without restricting peripheral vision. So there's several drops that are available or near FDA approval, which are based on pilocarpine, carbachol, aceclidine, and various other combination therapies. Interesting to note, the ASCRS recommendations, it's very strong points, inform patients of increased risk for retinal detachments. You must perform a dilated fundus examination before starting the drops to evaluate potential for RD, and makes patients aware of signs and symptoms of RD to seek urgent medical attention. So, as we know, these drops have those risks of causing a retinal detachment. So his conclusions were listed here. More people are aware of presbyopia now because of our digital devices. There's different options for those who want to be rid of glasses. The therapeutic indications are needed for patients of RK. Oh, you're on the grand rounds here with David Yan. So thank you. He didn't say anything inappropriate, thankfully. We caught him before, so. Anyways, drugs in trial have promising data. Adoption of these treatments will be based on quality of vision, near vision, side effects, and duration of action. Patients need to be aware of the risk for RD. Very important. So, and the king, Dr. David Rootman, gave a great talk on the current refractory surgery options, and all distills down to this one table he gave, which was really, I think, was really great. So for myopia, when you have less than -10, meaning 0 to -10 diopters with normal topography, tomography, and residual stromal thickness greater than 300 microns, it recommends LASIK or SMILE. If you have the same with residual stromal thickness less than 300 microns, meaning a thinner cornea, then PRK may be the better option. If you have less than -10 diopters with abnormal topo and tomography, then a phakic IOL or clear lens exchange is probably recommended if you meet all the criteria. Now, if you have higher than 10 diopters of myopia with an anterior chamber length depth greater than 3 millimeters, an ICL or an artisan would be beneficial. But however, with less than 3 millimeters AC depth, a clear lens exchange would be recommended. And on the flip side, for hyperopia, if your hyperopia is greater than 3 diopters with an AC depth of greater than 3 millimeters, phakic IOL is probably the best option. Greater than 3 diopters with AC depth less than 3 millimeters, clear lens exchange would be best. Less than 3 diopters astigmatism, less than 3 diopters hyperopia with normal tomography, and normal stromal thickness, LASIK is excellent. And less than 3 diopters with normal topography and tomography and thin corneas, PRK would be better. So Dr. Chris Rapuano talked on the management of refractive surgery complications, including DLK, which is basically the need for topical steroids, coverage of antibiotics, possible PO steroid use, flap lift and washout, culture. Delay can lead to stromal thinning and hyperopic shift. He focused also on central toxic keratopathy, fairly rare condition, non-inflammatory reaction. Prevention treatment unknown, causes flattening and hyperopia, but over time the refractive error does improve, but is something to be aware of. Pressure-induced stromal keratitis is an elevated intraocular pressure secondary to a fluid cleft and low intraocular pressure management. So you're actually, the flap is there. When you're checking the pressure, it's actually lower, but it's actually super high pressure is causing the cornea to swell. So you must DC the steroids and use glaucoma meds and check the IOP peripherally with a tonal pen, not centrally like you normally would. So that's pressure-induced stromal keratitis, something to be aware of. In striae, he talked about poor flap alignment, trauma and epi defect may need to be relift the flap and reapply it, or possibly even a contact lens or suture. And then epi ingrowth, he talked about how that can be very difficult in management to treat. Basically, treat it with lifting and scraping when it's more significant, suturing the flap using PTK or YAG laser. Dr. Chris Rapuano talked about all these things. He basically said conclusions, the LASIK and surface ablations are safe and effective procedures for most patients. Most complications do not cause significant problems if managed in a timely and appropriate fashion. So the essentials of astigmatism management, you have all these options here. I thought it was very interesting. Toric versus LRI for astigmatism, greater than 1, this is what Dr. Kim recommended, greater than 1.25 diopters, use a toric lens. Between 3/4 and 1 1/4 diopter, use against the rule, and then against the rule, use a toric IOL. However, if it's with the rule or oblique, use a limbal relaxing incision. So I was trying to figure this out, what would be the best, what explains that, and not really sure what that is. And then if anybody else on the panel can explain that. My thought is because most people progress to against the rule as they get older, that's why he's using toric IOL, because people, whereas the limbal relaxing incisions can change a bit. But maybe Amandeep, you can enlighten us on this.
You know how I thought the same thing when he was presenting, and I think probably the most logical explanation is simply that they don't have T2 torics in the US. And so there's a lot of LRIs happening for low amounts of astigmatism, whereas in Canada, we're fortunate to have access to lower power torics than they do in the US, and that probably reflects his nomogram there. Okay,
and that makes sense too, because if you look at the next section, and then talk about rotational stability, better to be on target, obviously, but we also talk about the posterior corneal curvature. So this little mnemonic, which is very important, add a T-step for against the rule, withdraw a T-step for with the rule, which would then support the need for a toric IOL in against the rule, because if you have, let's say, 1 diopter here, you really have another addition because it's already against the rule for the posterior curvature. So that's why he's probably adding the toric IOL there. But that's a good point. Excellent. Okay, Dr. Joan Lloyd, former program director, with the radio voice and the dashing good looks. Anyways, cataract surgery planning, post-refractive surgery. Yeah, hyperopic surprise, usually following myopic LASIK. Myopic surprise, usually following hyperopic LASIK. So sources of error can be from many things, such as the corneal power, where you overestimate the K and underestimate the IOL power. K error, basically measuring outside flat central corneas, which overestimates power. And estimation of the effective lens positioning, can also cause all these things. So we talked about the good, which is the Barrett True K, built into IOL Master, and as well as the Astros and APACRS websites, which are very good. The bad, unfortunately, only 67% of patients have had post-refractive get within a half diopter of the target. And the ugly, the risk of significant refractive surprise still exists. Patients must be warned of this. So there's a good spaghetti Western. He also knows what a spaghetti Western is. That's the good, bad, and the ugly. Terry Kim, he did a lot of work on Saturday, addressing the typical cornea and cataract surgery, basically manage ocular surface disease, ABMD, Saltzman's nodules, pterygia. Contact lens wear can alter IOL calculations. I thought this was very interesting too, because I use this kind of same treatment here. If you wear soft contact lenses, I ask the patients not to wear it for 2 weeks before doing their IOL counts. Soft toric, he said 3 weeks. RGP, impossible for people, but 3 weeks per decade of wear. So if you've worn RGPs for 3 decades, you'd have to not wear them for 9 weeks. I typically just ask, practically, I just ask patients not to wear their RGPs for a month before doing it, because it's only reasonable. Clara Chan, cataract surgery in RK patients, some great Pearls, use a 2.2 millimeter blade between RK cuts or a scleral tunnel. Personally, I just do a scleral tunnel on everybody. Cornea Protect is better optics because of the irregularities of the RK wounds. So it's nice to have that kind of viscoelastic on top. Use the lower bottle height. Femto laser assisted cataract may reduce phaco time to suture wounds. Always aim myopia, as they do regress to hyperopia over time. The Barrett True K is great. The Hague is great. Do not perform immediate sequential bilateral cataract surgery for RK patients, and make sure you counsel them about the appropriate expectations. Dr. Aldave gave a talk on the science of sight, another great one, addressing corneal blindness in the developing world. And basically, the main points were prevent corneal ulcers, increase the supply of donor corneas for transplantation, including importing tissue, using locally recovered tissue, changing the one donor, one recipient paradigm, as we have here. In other developing countries, they can do a DALP and perform a DMEC, both from one donor tissue. But here because of which makes sense, for infection prevention control, we do only do one donor for one recipient. Also increasing number of trained surgeons by training. All this cannot be done without financial support, learning about the blindness in the region, and developing local relationships and long-term relations with these surgeons locally, and develop an effective skill transfer model. The last speaker of Walter Wright was Dr. Steve Arshinoff, who gave two excellent talks. And he gave away his new book. He's on the immediate sequential bilateral cataract surgery, where there was 2 winners. He gave one to our residents. We're very kind of Dr. Arshinoff for that. So his commandments were the complexity of ISBCS should be within the competence of the surgeon. So you must be competent to perform this. Make sure you reduce, we must reduce the risk of right to left errors by keeping info visible to all in the OR on a screen or board, and make the procedure consistent. You need consistent OR personnel familiar with IOLs and calculations, and strict aseptic separation of right and left eye procedures. Single use for instruments and disposables to prevent infection. If you have an unresolved complication for the first eye, obviously you must defer the second eye. So those are the commandments that he listed. He also said that phaco and flax are possible if you feel comfortable in doing them all. However, M6 is not recommended. Many people have asked, what is M6? Manual small incision cataract surgery. Okay, it's not recommended because it has larger incisions, usually done in camps, and then the follow-up, you're not sure, especially if you're doing this internationally. So conclusions that he had historically, ISBCS was preferred, but poor success rates. However, development of infection control, phaco, and IOL advances have made it appropriate and correct indications. And finally, Dr. Arshinoff gave a nice talk on the CNIB I-band. Northern Ontario has poor accessibility to ophthalmology services, lack of family doctors, lack of pediatric examinations. The I-band travels over 6,000 kilometers every year, reaches 31 remote communities in Northern Ontario. It's amazing work. Thank you, Dr. Arshinoff, and all ophthalmologists and staff who volunteered their time for this noble humanitarian work. Really, a real kudo to everyone involved there. Thank you. Special thank you to my co-directors, Dr. Singal, Dr. Slomovic, Dr. Josh Teichman, and the planning committee consisting of Dr. Michael Nguyen, Amrit Rai, Marissa Sitt, and Yellen Yang. Of course, the boss, Sandra Gauchi, all our speakers, local speakers, and special thank you to Dr. Ryan Mason, Dr. Jen Quinn for helping me pull together this talk by getting all the photos for all the summaries for the slides. Thanks, everybody. Any questions, Amandeep?
No, the chat box has been pretty quiet this morning. You've done a great job at summarizing that meeting. That was a whirlwind review in 30 minutes, a day and a half of information. I'll just echo what you said, Hall. I think you guys did a tremendous job. So congratulations to you, Neera, Josh, and Alan for an amazing meeting. It really was a very successful weekend. Really nice to see so many colleagues back in person. I think a lot of people enjoyed that. So kudos to all of you in running a successful in-person meeting, despite all the challenges that you had and the uncertainty. Because remember, these guys were planning this meeting a year ago. And there was a lot of uncertainty a year ago whether a meeting could happen in December 2022, and they pulled it off. So congratulations to you all. Next week will be our final grand rounds of this academic year. with Dr. Karani speaking on glaucoma. And then we will take a Christmas break. There's no further questions, just a lot of comments from Mahmood and Yishay and Amrit saying great review, Hall. I echo all of that. So congratulations to you and your committee once again. I wish everyone a wonderful weekend, and I'll see you guys next week.
Happy holidays. Great job, Hall.
Yeah, thank you, Alan, for everything. That was amazing. You're the kingpin for this, man.
Well done.
Yeah. Happy holidays, everybody. Stay safe. See you in the new year.
See you next week.
Next year.
Bye.
Bye-bye.
Bye.